Good afternoon, and it's a great pleasure to be here, and it's really very encouraging to see this issue being prominently figured in this Congress. So that hasn't been the case in the past. So I'm going to give you a quick overview of the prevalence and health consequences, highlighting some of the work that we've done, and then talk about the role of the health sector in prevention, and finish with some of the significant things that are happening in the global context that will support some of the work that we are doing in this area. In 2013, we published the first global and regional estimates on the prevalence of primarily intimate partner violence as well as non-partner sexual violence. And this was based on review of all the data that we could get our hands on. And we see that in the last decade, there has been a growth in the number of countries that are beginning to document violence, but there are still big regional gaps. There's regions with limited data. And there are also challenges in countries doing surveys in a repeat manner that will allow us to look at trends. So a lot of progress in terms of documenting, but still some challenges in actually capturing the magnitude of the problem, and particularly in some regions. Mary already mentioned the overall estimate that we came up with was of 1 in 3 women. 35% of women reported having experienced physical and/or sexual partner or non-partner sexual violence in their lifetime. And we see in the slide that there's regional variations with the high-income countries, which would include Australia, around 23% lifetime prevalence, and all the way to Southeast Asia and Africa, around 37%. And these figures hide a lot of differences also between countries and within countries. We know also there are big differences. And these differences are even starker when we look at current violence in the last 12 months, where we see in high-income countries between 3 to 6% of women reporting violence from a partner in the last 12 months, compared to 30 and up to even 50% in some countries. Big differences in terms of the ability of women to leave relationships, which affect those last 12 months prevalence. This slide just to highlight that the violence starts early. Even in the 15 to 19-year-old group, we are already seeing high rates of intimate partner violence. Another thing that is that there's very high levels of violence during pregnancy. This is data from our multi-country study, which looked at 24,000 women in 10 countries. But when we look at the rates across countries, we find anything from 3% to up to 20%. And when we look at clinical samples, the rates are much higher. And I highlight this because obviously it's related to a lot of women's health problems like maternal depression and postnatal depression, which have a long-term impact also on child development. So very important, and in spite of these high prevalences of violence during pregnancy, we still do not systematically screen or identify violence during pregnancy as we do for other risks that are not necessarily as prevalent. Moving on to the health consequences, there's plenty of evidence now of the association of violence with many health outcomes. The most obvious ones, of course, and this slide illustrates also some of the pathways for those health outcomes, including unwanted pregnancies and reproductive health outcomes, as well as chronic diseases which are related to chronic stress and mental health outcomes. We also have documented that 38% of murders of women globally are caused by intimate partners, compared to about 6% of murders of men. So everything from death to high-risk behaviors to acute conditions, chronic conditions. In the same study in 2013, again based on systematic reviews of the literature, we documented the association that women who have been exposed to violence are twice more likely to be depressed, almost twice more likely to have a alcohol use problem, 16% more likely to have a low birth weight baby, 1.5 times more likely to have acquired sexually transmitted infections, and on and on. I mean, this is really just to document and highlight the health impacts, which to probably most of us in this room are pretty evident, but we still find a surprising number of people who say, well, but why is this a health problem? You know, it's a criminal justice problem, or it's a social problem. So documenting the health impacts has been important to bringing it to the attention and to highlighting it as a public health concern. I'm not going to go on with more of the health outcomes. But in addition to those health outcomes, there are also important outcomes on children of women who experience violence. There's data shows that about 34% and 40% of households, children have witnessed parental violence, and there's a high co-occurrence as well of violence against women and violence against children in some households. And we know that exposure to witnessing violence as well as experiencing violence themselves has long-lasting impacts on children, including behavioral and emotional problems and school performance issues, and that it has also an effect on families and social and economic consequences at all levels, in terms of the services incurred as well as in terms of impacts on productivity. This is a slide that I have borrowed from Emma. So, and what I like about it is that this is showing the different factors that we know to be related to violence, and we know now that it's not a single cause, that it's really a combination of factors at individual, relationship, community, and family level. What I like about this slide is that it has added also the global level. And throughout all of these different factors, the issues of gender inequality and gender discrimination, which we will hear more about, are permeating all of the factors that we know are related to an increased risk of violence. And it's important that we understand those so that we can address them and make our programs, our prevention programs, be responsive to the evidence. A lot of the focus of the research in high-income countries has focused on the responses to violence, but in low and middle-income countries, there's a surprisingly big number of interventions that have focused on primary prevention, addressing factors like women's economic empowerment combined with gender training, and there's a considerable growing body of promising initiatives around primary prevention that I think will be presented later and we can come back to. But we also highlight in terms of the health sector that while a lot of the health sector focuses on secondary prevention in terms of responding to violence that has already happened, there is also a continuum of prevention, and there are specific interventions in the health sector that can have a primary prevention focus, and that we need to look at those health sector interventions with that primary prevention lens. So this is just to illustrate what I was saying. We have the primary prevention trying to stop the violence before it happens, secondary prevention and tertiary prevention. Secondary prevention focused on early identification and early response. And this is a traditional public health model, and we sort of tend to box things in these individual boxes, but in fact, there is really a continuum of prevention, and some of the actions of the health sector that are responding to a woman who's already in an abusive situation, if we are also paying attention to the children of those women, can actually be having directly a primary prevention effect, because we know that exposure to abuse in childhood is linked to later perpetration or experience of violence. There is evidence that home visitation programs that are implemented often through health services can have an impact on reducing child maltreatment, and they are increasingly also being looked at to reduce and address intimate partner violence. So there's opportunities for combining things there. We had an interesting discussion yesterday about the role of substance abuse programs in, again, early identification and understanding those links between substance abuse and late violence. So there's a lot of opportunities within the health sector interventions to have a stronger focus on primary prevention, as well as doing their role on responding to women and to women's needs in a way that also contributes to reducing recurrence of violence, strengthening women's ability to make their own decisions about how they address their situation, and addressing also the mental health component, which again, in turn has primary prevention impact. So a lot of scope for strengthening that role of the health sector in prevention. Yeah, these are just some of the things I had mentioned. Home visiting programs, they've been assessed for child maltreatment. They're currently being assessed for intimate partner violence, and there seems to be some promising work there. One of the things that we have been doing as the World Health Organization is to develop norms and guidelines for the health sector on initially the clinical response and also the policy response. We've covered different areas with a strong focus on what it means to provide women-centered care and care that really responds to the needs of women. Issues around identification and care for women experiencing intimate partner violence, for sexual assault, but also looking at what are the elements, the policy elements to do with training, to do with transforming the health system in a way that allows providers that are trained to deliver their appropriate services. And we have also developed a clinical handbook, which is a very practical how-to manual that is helping healthcare providers to learn in a very practical way what it means to provide women-centered care, emphasizing empathetic listening, responding to needs, helping women connect to other services. And one of the things we have found as we've rolled these guidelines and this clinical handbook out in countries is that there's a big gap in terms of the health system. So even if you have very well-trained providers, often there are many challenges with the system itself and with just the infrastructure. Sometimes there may not even be a private room or a safe space within the health clinic. So we're developing a parallel manual that is also looking at what are those health system things that need to be in place to be able to support the providers. And we're working on curricula for healthcare providers. So I want to mention, before I finish, two sort of global political issues, context that we have now that will support our work and will enable us to hopefully make progress faster, which is firstly the Sustainable Development Goals. The Sustainable Development Goals were goals agreed by all countries of the world and towards sustainable development, peace, and health from now to the year 2030. And they are the sort of follow-up, the continuation of the Millennium Development Goals, which went from 2000 to 2015. And those Millennium Development Goals did not include any reference to violence against women. The argument was that we didn't have enough evidence and that we couldn't, really put them there as one of the targets to be measured. In the Sustainable Development Goals, we have for the first time a recognition that violence against women, or rather that the elimination of violence against women in all its forms, is a critical component for achieving sustainable development and health. And this is a significant political gain, which really speaks to the work and the research of many people and the advocacy that has gone on to make sure that this is recognized as one of the targets that needs to be measured in order to achieve the goal specifically around gender equality and women's empowerment. And there's many other sustainable development goals that are also linked to a prevention agenda. They are issues around poverty, issues around political participation, et cetera, that are all part of the prevention agenda, which I hope we have some more time to discuss in more depth. The other thing I wanted to mention is the global plan of action to strengthen the role of the health system in addressing violence, in particular against women and girls and against children, which was approved by the World Health Assembly in last year in May of 2016. The World Health Assembly is the gathering of the 193 member states that make up the board of WHO. And this global plan of action basically agreed 4 strategic priorities for responding to violence, including the strengthening of the leadership and the governance role of the health system itself, strengthening the access to comprehensive health services and including building the capacity of providers, strengthening prevention and evidence-based prevention, and lastly, strengthening data collection and evidence. And for each of those strategic priorities, the plan has specific concrete actions that governments have to do, that WHO has to do, and that partners, local and international. And this document is a political tool as much as a technical document, because these are actions that governments have signed on to and that they can be held accountable to. And just to end with this, that every sector has a role, and clearly the health sector is just one in a range of sectors that need to be involved to address this issue, and prevention includes everything from education, justice, legal, police, to health. But what I hear often when I go to countries is that the health sector seems to be dragging behind, or seems to be needing to be pulled up into this multi-sectoral response. And every action, small action by every actor in every sector, makes a difference. So I'll stop there and look forward to the discussion. Thank you.